This is the next slide, please. This is a 67 years old female patient with a hip intermittent claudication and a history of hypertension, dyslipidemia, severe smoking, severe COPD, and the patient related a year intermittent claudications, progressive and disabled from 500 meters to 50 meters nowadays. The other, please. Next one. The ECG, we saw a synosism with a normal ECG. The blood test, as you can see, is normal. The echo Doppler showed us a left ventricular preserved ejection fraction with a mild hypertrophy, and the peripheral echo Doppler, a slow flow in both common femoral arteries with the ankle brachial index below 0.5 at bilateral legs. The coronary and the peripheral femoral popliteal and below the knee angiography doesn't have any kind of lesion, non-significant lesion. The other one, please. This is the CT scan where we can see a severe, critical, calcified, eccentric, infrarenal abdominal aorta. At the left image, you can see that the severe critical lesion, and at the right one, the severe calcification, the concentric severe calcification. The other one, please. In this slide, no, sorry. In this slide, we can see the proximal and distal mean iliac diameters, the right one between 6.0 and 6.1, and the left one between 9 and 11. The other one, please. In this slide, we can see something very interesting, the proximal and distal landing zones between 14 and 13 millimeters with a calcification around the aorta, and the length of the aorta between the renals and the iliac bifurcation of 70.8. Next, please. This is the angiography where we can confirm the critical eccentric and severe calcification infrarenal stenosis without compromission of the iliac arteries, but the right one has a mild stenosis, with also severe calcification. Next one, please. So in summary, it's a 67 years old female patient with hypertension, smoker, COPD, and abdominal aortic stenosis. The heart team discussion conclude for the aortic PTA, especially because of the COPD and short stenosis. The other one, please. And the strategy in this complex PTA will be percutaneous femoral access bilateral, CP cover stent for the infrarenal stenosis, and a provisional kissing setting for aortic bifurcation. So next one, let's go to the cath lab.
Okay, thank you, Gustavo. So as Gustavo already presented to all of you, we have a very tight abdominal aortic stenosis, and it's very eccentric, and it's I would say very near to the bifurcation. This is, I think, probably the main technical issue, which is the proximity of this stenosis with the bifurcation. The first, I think, problems we are going to face are the following. Gustavo has already done the bilateral 6-frame puncture. I will discuss then why bilateral. Then we have to use a 12-frame sheath. Julio, is that correct? So the idea is to introduce an angiosyl, ProGlide before. So for that, I had to cross the lesion because the ProGlide is going to cross the lesion.
Right.
Because I don't have enough space on the iliac artery to a proper deployment of the ProGlide. So first, I had to cross the lesion. I'm going to deploy the ProGlide, and then I'm going to lose the position again. So I had to recross after introducing probably we have to prepare an 11 French sheath for here after the ProGlide. Prepárate un 11.
Okay.
And then the other problem we have, and this is the discussion that we were discussing a lot, is about how to deal with this stenosis. We have several issues to discuss, and that's why I put this patient, because it's a little bit uncommon. First, because it's very uncommon to have normal coronary arteries, totally normal peripheral artery disease with such a significant stenosis in the abdominal aorta. For us, this is a typical lesion of the women with heavily smoker women. Or if not, it's the situation of a Takayasu's disease. But this is not the case of the patient. She doesn't have any kind of syndrome like the inflammatory disease. She is a heavily smoker. She smoked 2 or 3 packages of cigarettes since she was 13 or 14 or something like this, and until now. So absolutely, this is the reason. Second is when severe aortic stenosis, we usually use uncovered stent.
Yes, you're right.
You can use self-expandable in most of the cases, or balloon expandable. The self-expandables are probably not so bulky, but balloon expandable are more precise, especially when we have to go very near to the renal arteries or very near to the bifurcations. But here, according to the anatomy, the plaque is so against one wall of the right side of the aortic wall, and it's so close to the bifurcation that I don't know how much we can be precise on the deployment. Probably the stent is going to be ending in the plaque, no below the plaque, because the 14 or 16 millimeter balloon that we are going to use is we cannot inflate too much inside the iliac artery. So the idea is to get a deployment acceptable, and that's why I chosen to go for the right, because if the stent is in the middle of the abdominal aorta, it's going to be difficult to re-engage from the right, and probably easier to re-engage for the second wire from the left. And after we have the kissing wires, we can do kissing balloons. And we are going to get probably an elliptical configuration that probably somebody will say is not okay, but probably I think it's okay here, because if we have a complication, we can put 2 graft stents in an elliptical configuration. It's going to be probably a more sealing situation than a circular configuration of the stent. A lot of technical issues. I know that probably many operators would do some different, but this is our plan. That's what we were thinking and discussing with Gustavo and with the whole team during the days before to do this special case, because it's actually, we have done a lot, but it's not so common. Absolutely. So
question.
Gustavo,
Why did you decide to put a covered stent instead of regular expandable balloon stent?
We still have the chance to change, but I think we have to push this plaque a lot, and the abdominal aortic on the other side is, between brackets, normal. So I scare a little bit about the inflation. If we have to push a little bit harder or inflate a little bit harder. ¿No tenés lo de los rotadores blancos?
Are you worried about a perforation, aorta perforation?
Yeah, that was, I was talking about that, exactly. And another issue is here, I think Gustavo has already done, we have a radial access, because this is a live case and we don't want to be there putting a radial access during the live transmission. And it's completely covered, but this is sterile there. Yes. And just prepare and just in case. Why? For 2 different reasons. One, if you have difficult for crossing, unfortunately it was not difficult, but if we have, difficult for crossing from here, we can go from above, and we can cross the lesion from the abdominal aortic and snare and pulling and doing a rail. And second, if we have problems during the delivery of the stent and we have problems to recross from below, for all that reason I was speaking about, we can go again from above.
Yeah.
So in a way, it's a protection. Yeah.
Yeah.
Okay. So fortunately, we could cross very easily. I think we can put now the let's put the regular shade wire,
Okay.
and so we can put the ProGlide. So let's check that I am not on the aortic wall because it was an hydrophilic wire. Mostrarme un poquito más arriba. Another tip. We are perfect because hydrophilic wire, are aggressive, and you can be on the aortic wall. It's not a good idea to cross with a catheter and to produce distal aortic dissection.
Meanwhile, we can say that this is a class 1A condition for a PTA angioplasty because it's a short calcified stenosis. It's not a task C and D that we can discuss about surgery versus angioplasty. Do you agree?
Yeah, absolutely. And this is a very important comment because well, this is an obese patient with COPD, but in case there was not, there's not that situation, this is probably a case for abdominal aortic surgery. But I think PTA is less aggressive, very fast recovery, and I think the outcomes that we have on the patients that we have, it's really good. So I think there is not a reason for surgery on this patient so far.
Yes. And the second is that what you told us about cover stent in the COVES trial was shown that the stent graft has better results than regular stents, especially in comorbid complications and breast stenosis. That's why perhaps this is a good case for this kind of stent.
Yeah, give me the wire. So let me check where. Let me check dónde estoy. I think I'm saying that's what I was saying before. Let's check with the shade wire, but I don't think I can cross.
The tip of
the tip is below the lesion, you see, and this is okay. We can do it there.
Okay.
Hold it, the groin, Joaquin. So it's extremely important not losing the position.
Then another point I want to mention is that it is very important to have a very good experience in one study. The Omalitage study showed us that centers with very good experience has less complications and better results from, for example, stenosis from 7-8% to 15%. So in our institution, we have performed a lot of aortic angioplasty, and we know how to.
Yes, actually, we don't have data very recent, but to be honest, I don't remember an aortic stenosis of the cases we have done. We usually follow with echo Doppler and with CT scan. So we usually do a CT scan after 1 or 2 months, an angio CT, and then we follow them with the echo. If the echo is okay, we don't repeat the CT scan, but if on the echo we have some restenosis, we can go for another study like angio CT or something like this. To be honest, I think the risk of restenosis is especially for iliac arteries, not for the aorta. The aorta is extremely rare to have a restenosis. Okay. So now it's the predicted situation. I have to recross the lesion, and hopefully this is going to be the last time I have to do it. Okay. Hold the wire a little bit. Okay. Okay, so, let me tell you something. Our former boss, for Gustavo and myself, always told us that one good intervention is one who can repeat the maneuver, because the first could have been done by chance. So it's just to remember our boss, Dr. Londero, that probably he's watching us from Córdoba City. Dr. Londero is also very close friends of Dr. Meta. Okay, so once again, I am checking in the true lumen. And Andres, you have a question? Well, I think here is going to be a 12 French sheath. So if we are closing 14 or 16 with only one, I think there is no reason for using two. And probably we are going to use the same technique that we used for the previous case. We are going to leave the wire and also the six French sheath. And then we will check. If we are bleeding, we can use additional ancho seal or no. This is a patient without any kind of other comorbidity or procedure or whatever, so we can revert the hyperonization. That is going to be, let me tell you, very helpful. And for young patients, young physicians, let me tell you that Gustavo and I have to hold the groins with 12 French sheath for hours and close it by compression when we were young. So we don't care about the 12 French sheath. Anyway, you can have a complication, even with the 6 or the 7 or with the 8. So here, our plan is to see, unfortunately, we forgotten to upload the CT scan, because with the CT scan, we could have used the vessel navigator, but let me tell you, I've forgotten. So Jorge, can parar de respirar? No.
Apnea.
So here we have. Okay. Perfecto, listo. So according to, ¿podemos frizar? There.
Okay.
So according to our measurements, the upper part of the abdominal aortic is 14 point something. It's not bigger than that.
Yeah.
And below is probably 12. And then we have the stenosis. So I think, let me tell you about the length. From the bifurcation to there, we have 1, 2, 3, 4,
60.
4, 5, 6. So let me check with which stent do we have a cover stent. ¿Qué stent cubierto tenemos? Sí. 60. Ok, 60 por, ¿de qué diámetro? 14.
14.
I have to, okay. No. Ok, el de 14. Ajá. O sea, in this case, I'm going to need una vaina de 13, 13 sheath. Okay. And I have to, lo tengo que montar en el balloon. Do you have the balloon? Okay, let's go. So we have enough time. Okay.
Por 60.
Gustavo, do you plan to do the echo? Do you like to do the echo now or afterwards?
I prefer right now.
Wait a minute. Give me la guía 018. We can do echo. We can confirm the measurements, and then we can decide based on echo about the measurements. I might need some clock. I have here. Okay, it's okay.
So
we are the time.
We are going to use the 0.018 wire with a Vulcano echo. We can use, yes, we can choose two kinds of echo in this case. The 0.018 and the 0.035. The difference are that the 0.18 goes, diameter goes up to 20, and the 0.035 goes to 60. So I think that in this atherosclerosis stenosis, we can use the 0.18, or we can do it in that way.
We will check.
We don't need to use the other one that is
always used. La bolsa del eco?
For aneurysm.
Sí, necesito. Okay. Okay. This is the manual echo.
Yes.
Okay.
Please.
Take your time.
Sorry. Yes. Okay.
So this echo is mostly used here for venous intervention, Dr. Gural.
This is solid. The solid one.
Yeah.
Where the transducer doesn't rotate.
Yeah.
Okay.
And it has
64
here,
transducers that are fixed, and we can see the image with this solid state.
Okay, perfect. So let's see. Can you share the echo, please?
And the other advantage of this echo is that we can pass through the lesion
very easily
than the other one.
So there, I think we had to change for the other one because here.
No, yes, we lost the image.
We lost the image. Yeah. So we had to use the other echo.
Okay.
But let's check. Also, there is the upper part of the abdominal aorta. Here is gonna go through the lesion, which is is coming here. So you see 1, 2, 3. There is a very tight stenosis. So this is 1 or 2, 1, 2, 3, 16. It's okay. And this is the bifurcation. You see a flap there on 12 o'clock. And here is the iliac artery with some plaque, significant calcification there. Let me check here. Calcium, plaque, calcium, but not tight stenosis.
Moderate stenosis.
Moderate stenosis. Yes. There is a little bit
a mixed
worse.
plaque, no?
Yes. So near the bifurcation with the internal iliac artery, and this is gonna be the external. Let me go there. So there is the hypogastric, and here is the external iliac artery. So to be honest, I think we have to fix the aorta and then to check.
Okay.
Here I am inside the sheath.
The sheath, yes. ¿Me hace otro eco? El de 035, el otro eco. No, lo hacemos con esta misma cuerda.
Give me the other echo.
Yeah. Yes.
Leave this there.
Yes, of course.
Okay, perfect. Patient, of course, is absolutely stable. Yep. So give me the other one. If we have a better imaging of the abdominal aorta, here this echo is also good because we have markers, 1 centimeter markers.
We have to flush it.
Okay, agarrame la guía, Gustavo.
Yes, here.
It's
over the wire. This is an over the wire.
This is the main
This
difference.
is the for 0.35 wire, and this is for 8.2 French introducer French, and a 60 pullback millimeters.
No, esto es debajo. That's why tenemos baja presión porque estamos en la ilíaca. Okay. So here is the stenosis. And resistant for crossing, you see there is a very tight stenosis, and there is the abdominal aorta calcification that was referred by Gustavo. Here is the, I would say, normal, which is 1 less than 2, probably 16 or 18 or something like this. Do you agree?
Yes.
So let's go back to the plaque.
Would you like to show the renal arteries?
Yeah, renal arteries are here.
Yes.
There. And this is the venous, and this is the renal artery.
You are right. At the upper screen is the venous renal, venous renal, and the other one are the renal arteries. Yes.
Let's see here. The aorta is small. Is 1, 2, 2.5, something like this. Which is is
1, 2.
Which is the dot? It says 5 millimeters, so it's 5 millimeters. So it's 1, 2.5. It's 16 or something like this. There, this normal. It's not 1 centimeter. It's 5 millimeters each mark of the IBUS. So that's why I think the 14 is going to be okay.
I think so.
And then we can post-dilate it. We can go up hasta cuánto. Sí. No, pero ¿hasta cuánto lo podemos postdilatar? This is the plaque.
Sorry, this is the plaque, the aorta plaque, and we can see the iliac has a.
Yeah, but I think this is a slow flow also because the introducer is 11 and.
Okay.
So we will do IBUS after deployment of the stent and we will show it. So give me the, give me
the right
or mammary catheter that we have, yeah. And when I introduce the amplats. Okay. Okay, so I had to crimp the stent over the balloon, no?
Yeah.
Okay, I had to work. Okay, no problem.
We can show how to crimp a stent. We have all experience.
Yeah.
Crimping stents with the Palmas.
Below Julio Palmas.
Yes. I think the IBUS is very important.
Yeah.
We have two important issues. First, diagnosis. We can see the lumen diameter and the wall diameter, of course, of the normal aorta, the landing and the distal landing zones. And we can also see the length of the stenosis. And for the therapeutics item, it's very important to show the calcium, the superficial and deep calcium.
So what can we do from here, from the left, is to introduce this right shotgun, and we can control from above, or we can check the bifurcation to be sure where we are delivering the stent. Let me cross, but probably afterwards I'm gonna pull, and before final delivery, I will be on the bifurcation, because this is our main problem, the bifurcation, not the upper part of the aorta, because in case we have a problem there, we can put another stent and that's it. So.
To complete the IBUS, it's also very necessary to study the patient after the treatment, and also to reduce the stent restenosis.
The gradient, it's okay. The gradient of the aorta, it's actually almost 70 or something like this. So we have here the sheath. This is 12, so we need 13. Okay, let me move here. Vení aquí. Gustavo can stay here.
Yeah.
And we are going to see. Give me this. So we are going to prepare the sheet. These sheets are curved. Actually, it's not necessarily the aorta, but anyway, we will. So we have to flush. And then we have the balloon, the Z-Med balloon. It's not B&B, no? Yeah, no. Okay, it's a Z-Med balloon. Okay. Dame una jeringa de 50. So, una llave de 3 vías, luego lock. Thank you. Okay, Pancho. Do you recommend to inflate manually or with the inflator? Manual. Let's check it for a 50 cc. Por favor. Okay.
The cover
So the
1460.
cover, yeah. Push to show to the camera the stand. Okay. This is contrast. Okay. Oh, okay. Perfect.
This is a CP stand, 14 in diameter and 60 millimeters in length. Please, can you give us? Thank you.
The sheet and platinum stand. Is that okay? Okay. So let me see. Okay. So give me the stand that
We have to use this one.
Okay. Yeah. Okay. So this is the
And I
peel
think
away.
this
Okay.
is the peel away we have to make. Sorry, we have with the we
I know.
have to cut it because
Yeah.
if not, the stand doesn't go through.
Okay. So I'm cutting here. To
The peel away, we have to cut it at the middle.
transform in a peel away.
Yes.
Probably the company in the future will do it.
Uh-huh.
Okay. And now here the stand. Yeah. I had. Okay. And I had to take my glasses out without contrast. Give me another one. Dame otros. Dame la vaina, la guía del introductor, la 035 de un introductor cualquiera, ¿no? La de las cortas.
Okay.
So Julio is recommending to first crimp the stand and then to put the peel away. Okay. Wait a minute. Give me a second.
No,
Could you inflate the balloon? No, this is not.
No.
Give me another one.
Or perhaps a small one.
It's for para 35, ¿no? Sí.
Okay.
It should be 38.
So
okay, inflate. Some water. I am going to clean it. Okay. Aspirate. Okay. So with that, we are trying to increase the profile of the balloon. And now I'm gonna crimp the stand.
Would you like to show the stand?
Yeah, no, give me. This is the stand. And this is the cover. I'm going to introduce the wire for crimping. So here I have to check the markers. It should be on the center. And let me crimp a little bit. I'm going to check on fluoro. If I am in a good position, let's check, Gustavo.
Okay.
Let's see fluoro. Here, I think it's perfect. Little bit up there. It's okay. So let's move back. No, vuelve como estábamos.
Okay.
Okay. So we can work here facing the cameras. So not rotating.
Some tips for this kind of angioplasty, if you agree, not to perhaps we have to predilate the stenosis with a balloon 0.7, 0.0 in relation to the aorta lumen diameter. The second one, use stents no more than 1 and 1. Try to
I'm trying to go probably 1 and 1 and more. I'm not going to predilate because I'm going to cross the lesion with the sheath.
Okay.
And I will cross the stent and put the stent in position. And then I'm going to pull the sheath and the stent should be kept on the position.
Okay. And
then it should be delivered there. So it's okay, Julio? Do you recommend to mojar o algo? Eh? Okay. Some water.
Some wash it.
So remember that.
Can I go out?
No, it's, yeah. Okay. It's okay. Yeah. And now it's a difficult part. So I have to be sure that the stent is completely compressed. I'm gonna take the time.
So you are going to make a direct stenting, and if it is necessary, to post-dilate.
Absolutely. So this is the biggest part. It's like a cone. I'm going to introduce here very carefully. Trying not to move the graft. So you see it's going smoothly. So the stent is there. So now we can leave the stent here. Joaquin is going to take care of the stent. We are going with the sheath. Now Joaquin can help us. The stent is going to stay here, there. And now Gustavo is going to hold the wire. Now I'm going to pull the 11 sheath French. The 11 French sheath, sorry. And now I'm going to introduce the sheath. I haven't cut the skin. Probably it is necessary. Let me check if I can go. If not, I am doing. Let me check. No, it's okay. So it goes very smoothly. So I'm crossing. Hopefully, I'm rotating counterclock. To go up. Mostrarme más arriba con un poco de zoom. So now Gustavo is going to retrieve the.
Do you think, as you did that movement, do you think it is necessary to perform this case with distal protection devices in both common femoral arteries?
No, I don't think so.
I don't think so. The risk of peripheral emboli is low.
Actually,
no more than
this iliac artery is going to be closed, and the other one. Póneme para inyectar, pone coronal izquierda, tener el stent que no se mueva para ningún lado, tenerlo vos. Let me check. So, móvete un poquito. So, I think, okay, we are going to advance the stent. We are going to leave in an acceptable position. Then we are going to check distally the position, and then I will move the sheath back. Yeah.
Like to perform road mapping? No.
But first I need to find where is the. Here we are going to have some bleeding. Don't worry. Thank you. So now I have to use this catheter I made to this device to introduce it, and then I can go further with the stent. Hopefully. ¿Tenés la guía fuerte?
Yeah.
No, it's not going, Julio. Let me pull this out a little bit. Now, yes. Is it bigger enough or we need a bigger sheet? Now it's okay. So what I'm gonna do probably is first to clean. Give me another, dame otro camisolín. Don't like to be on live full of blood. So before going out, I had to check the position of the stent. So everybody agree that the position is okay. Nothing has moved. So now let me go here. Yeah. Thank you. Dándemelo de atrás.
Meanwhile, what do you think about performing this procedure by CO2 or only IVUS without contrast?
Well, it's an option. But here, without the renal dysfunction, I think it's okay going like this. So let me check with Cine about calcium. Oh, okay, sorry. Inject again.
Yeah.
Oh, I
it's
think
occlusive. That's the problem.
It's occlusive.
But we can see the left
but
one.
I think we have to move here on a coronaria injection. And we
Manually.
have here. This is the carpal.
Manually.
Check it. Check. Minimum. Okay. Very, very careful. So I'm going to pull it a little bit lower. When inject here, Gustavo, very smoothly. Okay, the carrefour is there. The stent is okay.
Yeah.
We cannot go lower because we are going to be inside the iliac artery. So Gustavo is going to inflate. Let me pull first the sheath back. Let's take a very gentle shot. Okay. Try not to move forward. And now I'm going to protect the iliac artery. Test.
Would you like to check? Yes.
Yeah. So I think this is the position. Probably 1 millimeter above. Do you like it, Julio? Yes. Okay. Test. Okay. Let's go.
Okay.
Very slowly.
Up to 4.
Yeah. So I will try to keep the balloon in the position. I am taking into account the vertebra inferior border.
Yes.
A little bit more.
At 4. Oh, yes. Okay. 10.
Okay. Okay. See, okay. It's enough. It's enough, Gustavo.
Okay.
Because we have to be very careful with the carrefour.
Okay.
So let's dilate here a little bit up, a little bit more. So meanwhile, I will try to go in. You see, it's very easy, hopefully. I still have the balloon there. And then, prepárate 2 balones de 8 por 40.
More contrast, please.
Trae la jeringa de 50, Gustavo, o no.
Okay.
Okay.
Here.
Let's move because we are 20 minutes live. Dale.
No. Okay.
Dale. Inflalo. Okay. Okay, inflate. Tráete la guía hidrofílica o la J. La J mejor.
No, we need more contrast. Sorry.
Okay, it's okay.
Sorry.
Okay. Okay, let's pull the balloon
contrast,
a little bit.
Contrast.
Andres, any question from the audience? La guía J? Okay. So I'm not using the hydrophilic.
Llénamelo.
just trying not to cross between the struts. So I'm going here, and then I'm gonna rotate clockwise to go in, and I think we are in very easily. I will leave the wire there. Gustavo is gonna pull it. Here, which is 6, we are going. Vamos a necesitar un introductor 7. Bueno. Okay.
Do you need to postulate more? Because I go up to 4.
Okay. No.
No?
No.
Okay.
Pull it because it's too bulky, this balloon. I would rather like to use the kissing balloon strategy that we have already planned before.
Okay.
Okay. Let's follow this, the plan. Vamos, con 2 balones, 2 insufladores nuevos. Dame el intro, ¿esto qué es?
Balón. Déjalo acá. Introductor. Introductor. The sheet.
Preparar el introductor 8. Si no, no va a salir. Okay. So push the wire, push the wire.
Sorry. Yes.
Okay. Okay. I don't know where we are. Oh, here. Okay.
Yes.
Perfect. ¿Tenés esto, Gustavo?
Yeah.
Give me the 8 French sheet.
Introductor.
Okay. I have to be honest, I am very elegant without any blood on my scrap, but I am dying because of the hot. Okay, this is okay.
We have the other balloon.
Sí. Give me the other balloon. So let's see. Position is perfect, but it's like it was expected. A little bit push to the left wall and not to the right. And I think I was absolutely right, choosing the right, side for going with the stand. So here, let's go. ¿Estás? Vamos.
Okay.
Bueno, okay. Dale.
We are right.
6, 8, 10.
10.
Okay, that's it. Okay. One, 2, 3, 4,
4.
5, 6, 10.
10.
And now we are reaching the outcome we were looking for.
10.
Okay. Perfect. Yeah. So now we can pull the balloon. And give me a 10. ¿Tenés uno de 10? We are going to go a little bit further with the 10 millimeter. Do you agree?
Yeah. Wonderful.
Looks much better.
Yeah.
And you see how the left iliac artery has grown.
Yes.
And the blood pressure, which was 60 at the beginning, now from the distal part is
become better
without gradient.
Yeah.
So let's go that we only have
2 minutes.
I think, oh no, stop this close. Ese reloj que está ahí, no sé qué es. So, For kissing, it was 8 and 8, and now we are going for 10 and 8. So we are be very little bit careful. I don't know why they offer us 10 by 20 instead of 10 by 40, but anyway, we can go there slowly. We are be very precise. We are getting better outcome there. We can go. We can be a little bit aggressive because we have a cover stent. See. Let's go there, Gustavo.
Okay.
And I think it's okay. Let's one distal inflation here.
4, 6.
Okay. It is okay. Okay. Yeah. Will you retrieve this? Gustavo?
Yes.
And give me the pigtail. Let's do an ansio.
Okay.
See. Once again, comparing with our TAVI case, you see that peripheral cases also are time consuming. Gustavo here is our expert because he is very patient to deal with total occlusion on the SFA. Sometimes I get fed up about that, but Gustavo is very patient. So I will pull the sheet a little bit. I will do ansio here.
Yes.
15. No, I think estamos bien ahí.
Apnea.
Podemos apnea. Stop breathing.
Breathing.
Let's go. Let's go. I think we
Wonderful.
have a very beautiful outcome.
Yeah.
The que respire. The stent is very precisely deployed. It's flaring below the plaque.
If you want, we can take gradient
Yeah.
at this one and the pigtail
Yeah.
and compare gradient, or
yeah.
perhaps we can use IBUS, whatever you want.
We are going to do IBUS too. So here we have flash. Retira este, Joaquín.
We need another pressure.
No, we will do with the same.
Okay.
So let's check there, which is the pressure. Could you share the hemodynamic, Philip? It's 100 and, would say 105, something like this. Let me check on the other iliac artery. I only have one channel flash. It's okay. So no gradient at all.
No gradient.
From the abdominal aorta, which where the pigtail is placed, and this sheath, which is on the common iliac artery. I will pull the sheath to follow and to be sure that we don't have any gradient here in this iliac artery. Now we can put the wire here, the Amplatz wire, and then we can do IBUS to check if you want. We still have 10 minutes before give the transmission to Anita Apkar and his team in Canada. Let me check. Perfect. Okay. So IBUS is there. So once again, we have there 1, 2, 16 or something like this. The other marker is the other wire, which is parallel. I am moving here. You see, this is the wire. And now I am pulling. I am entering to the stent. The stent is well opposed, well open.
Yes.
Here I'm coming to the tightest part. Here is a little bit elliptical, which is as it is expected. It's a lot of echo refrigerancy there. And there is the distal part, which is 10 or something like this. So
Perhaps
probably
postulate
we can
here.
postulate here with the, let's check. We don't have to damage the iliac artery. Maybe we can use the same balloon, but a higher pressure.
Okay.
Let's go. Dame el balón del stent. We are doing something that we used to do. I will put the balloon a little bit inside the stent, going a little bit up, and I'm going to inflate manually. Let's go, Joaquin. Oh, it's a very bulky balloon. Let me clean it. Patient is under full heparinization. Go. Any other question, Andres? So let's go. So let's shoot the, dame la de 50. Okay.
Okay.
So as you can see there, the balloon is in the stent and a little bit above the stent on the upper part. I am protecting the iliac artery. I'm going to inflate. I'm going to go a little bit. This is a little bit painful. You know, we have recoil.
Yes.
But I think it's enough.
Okay.
We don't want to destroy the aorta. But wait a minute.
Okay.
Aspirate.
Aspirate. Yes. Aspíralo.
So let me tell you that I really push hard.
Okay.
Anyway, we have empuja la guía. We have recoil, something that I expected because we have a completely eccentric plaque. So let's check the gradient on the right iliac artery so we can discuss with the audience before leaving if we had to put a stent here or no. So Gustavo is flashing. It's okay. It's okay. Stop. And let's see on hemodynamic, we have 110 or 15 or something like this. I'm going to pull the sheath. See. Seguime. And I am almost out. And we don't have any kind of gradient. So all the lesions are not significant. I think we don't have to use any additional stent. We can inject here.
Yeah. Let me flush it with the contrast.
Yeah. If not, we can put the pigtail to the other side, Gustavo. Let me the pigtail. Give me the pigtail.
Okay.
Just not injecting in this huge sheet.
You can check also pressure, different pressure between infrarenal abdominal aorta and.
But we have already done.
You done the.
Yes, because we measured when the pigtail was below the renals.
Okay.
And we did for both iliac arteries. Okay, so I can do from here. It's okay. No, ahí nomás, más abajo. Más abajo. And pone un poquito oblicuo para allá. It's okay, ahí nomás. Okay.
Yeah.
Que no respire. Stop breathing. Okay, perfect. Let's go. Oh, I think the outcome is perfect.
Yes, it is.
We don't need to use any additional stents.
Sí.
So let's close the groin. De frente. No, separado. Give me the 6 French sheets. Okay, perfect. So le podemos revertir. Trae para acá. Luz. Ahí nomás, ahí nomás. Wait a minute, Gustavo.
Yes.
10,000.
10,000.
Ahí nomás, porque si no se quema la imagen de la cámara. Okay, sácalo. Empuja la guía que no sé dónde está. Ah, no, okay. So now I'm gonna put the 6 French. Yes. I'm gonna say 10 for the positioning, probably 6 or 7 because of the recoil, aflojame. But to be honest, we don't have anything else to do it because if we keep pushing, we can destroy the aorta because the plaque was completely eccentric and we are overstretching the normal aorta and pushing a little bit such a calcified plaque against the right side of the aorta. So, Philip, if you can show here.
And hemodynamically is perfect. We don't
and
have
additionally, yes, as Gustavo is saying, hemodynamic is 10. So I would say 10 for positioning, 6, 7 for the recoil, and 10 for the hemodynamic. With this covered stent, with the good antiplatelet therapy, the restenosis rate for sure is going to be very low, below 10, sure. Yes. I promise. Can you show here? Move más allá. Okay. And here, as you can see, we don't have bleeding at all. So now we can pull the sheath and we have bleeding. We have an unplugged wire, which is probably not ideal. Suéltalo, déjalo que sangre. So I think we can use an additional angiosyl. Gustavo, what do you think?
I'm sorry, I'm not seeing. Yes, perhaps. Yes.
Still, heparinization is not completely reversed. But, you know, we still have to do 20 cases in the afternoon. So bring me an angiosyl. Angiosyl. We need to leave the room very soon. We still have 3-4 minutes. Please move forward. No pongas ese reloj.
Are you going to put it?
This.
Okay.
So, Philip, we still have 2 or 3 minutes.
Okay.
So I'm gonna go here. You see, it's very easily when you have the wire and the space done with the 6 French sheath. While Dr. Jorge is reverting the heparinization. Okay, so that. And now we are absolutely sure that the groin was closed. We can cut here. We can cut here without cutting fucking fingers. If not, I'm gonna be killed from Ecuador.
Mm-hmm. And are you going to close the other one with the 8 French?
Yeah, but we can do afterwards. Okay. We can close the live transmission here. So, dame otro angiosyl. I don't know, Philip, if we still have some minutes. Dame una J común. O sí, una J común. 6.
For that one, 6?
Sí.
Okay.
A ver, mostrame dónde está la guía. So, we have the wire there. We have pulling here. And we are going to deploy the other angiosyl, and this patient can go home today.
6.
So he's picking the angiosyl.
We have an 8-1 and 6.
Vamos.
6.
No, it's okay.
Okay.
Okay. Any final comment from your side, Gustavo?
Well, several things. First, be careful with this kind of patients. They are too fragile. Second, try to be conservative in order to not to perform complications like perforation, vascular access complication, ileal complications, and embolization. Then try to use the right stent for the right lesion,
Okay.
and then try to use IVUS. I think IVUS is very useful for these kind of patients, as we said before. So this is a very good intervention for this kind of patients, and especially for short hospitalization and very low complications.
Okay, guys, we have already finished. Everything is okay. You can release. Here is okay. It's just to show you the audience that everything is perfect. Some small oozing here from the skin that we can hold it while the hyperonization is reverted. And we are happy with the outcome. If you zoom out, we can say bye. We are more than proud of our cases during this. Aleja un poquito el monitor. During this pilot period, and hopefully enough, we can be back soon. No, levántalo al revés. Levántalo. It's okay. It's okay. It's okay. We can be back soon in the near future, probably after 6 or 8 weeks after the holidays on the north part of the world. Our colleagues can enjoy, and we too here. And we'll see you very soon. Bye-bye.
Bye-bye.